I appreciate that we are doing this in the middle of the day here in the UK, and it's 5 p.m. in Malawi. So we will get a trickle of people coming in and out, but we would like to start on time because time is very precious. First and foremost, I just want to thank Dr. Khan for making time to come to speak to us today. I will actually give him the opportunity to introduce himself. Do excuse me for a minute. I've got a little one. Twani, please get out. Thank you. Working at home is not an easy thing. Yes, I'll allow Dr. Khan the opportunity to introduce himself. So Dr. Khan is a consultant physician respiratory. He's a respiratory physician and practices in general medicine. He is the clinical lead in respiratory medicine and the chief clinical and information officer at Darren Valley Hospital. Before I go any further, we will have a few house rules. So can we please keep all our mics on mute? Can we please have all our mics on mute? Thank you. We will unmute our mics when you're asking a question. And if you do have a question, please put your hand up, or you can type your question in the chat and we'll pick them up. And just to let you know, in terms of running orders, we are going to have Dr. Khan do 2 presentations. Firstly, he will talk about the COVID journey treatment and management, and then we will have a few Q&As. And then after that, he will talk about the recovery trials, and we will have a few Q&As after that as well. Before he starts, I'm just going to ask Charity to say a few words. She is our president for MUNA. So Charity, over to you.
Oh, thanks, Salah. My name is Charity. Good afternoon, all. I'm delighted to be here this afternoon. It's 3 p.m. in UK and 5 p.m. in Malawi. I'm really glad to have to see some familiar faces virtually, Dr. Lungu, Maggie, Ellen, and everyone else who's here. Thank you for attending our 3rd COVID-19 series. As I've been introduced, I'm the president of Malawi and UK Nurses Association. The main goal of this webinar is to gain some insights of COVID-19 management and treatment. This session is targeted at healthcare workers and some curious individuals who might just benefit from this. The reason we're here is because we've had a dreadful year due to COVID-19 here in UK and also in Malawi. We've seen people lose their jobs. We've seen mental health issues going up. We've come to see that there's long COVID, people with no other pre-existing medical conditions going on long-term oxygen post-COVID. In NHS, we've lost a lot of nurses and doctors. And in Malawi, we've also lost our fine doctors and nurses. So it is still a big issue. In UK, up to date, we've lost about 119,000 people to COVID. So that's just a number, but at the back of it, there's families, there's dads, moms, and daughters and brothers and sisters. There's been a lot that's been happening with COVID management. We've seen a lot, most of us on social media, whether it's pharmacological or non-pharmacological. We know that there's recovery trial that's still going on in UK, and things have moved on from where we were in April to where we are. Dr. Khan will definitely make this, I'll give it its deserved justice, because I'm not. Personally, I'm not up to date with management because my background is in critical care, but I've lost touch over the years. So I would say ignorance acknowledged provides a window of opportunity, but ignorance denied closes the door. Dr. Khan, as you're aware, as you might be aware now, he is a respiratory physician and he's worked tirelessly to manage COVID-19 patients. I hope this webinar will provide a window of opportunity for us to work globally as a network to address some issues, to question and share best practice. I'm hoping Dr. Khan will be keen to share his expertise with our colleagues, doctors and nurses in Malawi, maybe virtually, if possible, if that's possible, but that can always be organized. And I hope at some point in our journey of COVID, we'll be able to find solutions and engage in a meaningful way and find some answers. I am delighted to have Dr. Khan here, and I hope you enjoyed the session. Thank you so much.
Thank you, Charity. Just to let everybody know that today's session will be recorded. So if there's anybody who does not want to be seen or is camera shy in any way, please do turn off your cameras. And if you do not want to speak, once again, please use the chat messenger box and we will pick up your questions and your queries as we go along. And without further ado, I would just like to hand over to Dr. Khan. Dr. Khan, over to you.
Hello. Thank you very much for the opportunity to present at your webinar. It's a privilege and it's an honor to have these conversations and share our experiences with colleagues, not only about COVID, but other topics as well, and not only in the UK, but across the world. I think this has been a humbling experience, and it brings to the fore the concept of the global village, that we're all in this together and we've all been on a journey. So I've structured my talk into two presentations. The first one is about lessons learned, and the way I'm going to try and present this is to create a narrative about our journey that we've been on, looking after patients at the cold front from the first wave, and as we've gone into what is now called the second wave, and also just share some thoughts about what we can see going forward. I think we can recognize that across the world, different places, different countries, different continents are at different points of the epidemic journey. So I think there will be some valuable learnings that hopefully we can share. And I think you can also find some resonance in some of the things that I'll be presenting as well. The second talk, I'm going to be focusing about recovery trial, and I'm just going to talk you through the steps that the recovery trial has gone, because it has clinical relevance as well, that a lot of what the recovery trial was, that the learnings were implemented relatively quickly with all our hesitations and concerns as well. So I'm going to start with lessons learned, and I'm going to quote Donald Rumsfeld, who talks about known knowns, known unknowns, and unknown unknowns. And I think we were way back about a year ago in a lot of unknown unknowns. And then gradually we're coming to the phase where we think we know what we're doing and we think we know what the questions are, but we're beginning to identify those areas that we don't know much about as well. So it's been a journey, to say the least. And in our lifetimes, I think I can think back to the Ebola virus in 1976, the HIV pandemic in 1982, and this definitely is up there with these global viral illnesses. So this is a pivotal moment in our lives as healthcare professionals. So the way I'm going to structure the talk is I'm going to go through two cases that we dealt with at different parts during the epidemic, and then and intersperse that with some lessons and learnings that I think have been quite poignant and have been quite milestones for us in managing these patients at the cold front, and then just some thoughts about what the future holds. Though I promise you I don't have a crystal ball, so I'm more likely to be wrong than right. But it's still worth thinking about how we should be preparing ourselves, not just for this pandemic, which still is ongoing, but for future pandemics as well, because this is, I promise you, not the last respiratory pandemic we're going to have. So the first case was a 43-year-old gentleman. He was a BAMI, or a black gentleman, and he was admitted via A&E or the emergency department in September 22nd. And he presented with 4 days history of feeling unwell, dyspnea with a dry cough. He also had a temperature, and he complained of an altered sense of smell and taste. His background history was that he suffered from high blood pressure. He had had a history of being diagnosed with intestinal tuberculosis, which was fully sensitive to first-line treatment, and he completed the treatment course in 2011. He had a smoking history of 20-pack years, and he was on the heavy set side. And he was taking a number of antihypertensives. And on examining him, he did indeed have a temperature, but his respiratory rate was actually only 20 per minute, and his saturations on room air were 94%. And chest auscultation just revealed occasional bilateral crackles, mainly at the lung bases. And this was his X-ray at the time of admission. And the abnormality is that at the right lower zone, he's got increased haziness. So the differential diagnosis here, the history is suggestive of a lower respiratory tract infection, and the etiology for the lower respiratory tract infection could obviously be a COVID-19 pneumonia. That would probably be at the top of our list, but also as medics, we learn to think outside the box and always have a few more differential diagnoses up our sleeve. So this could be another viral pneumonia. September is a bit early for the common flu and the influenza pneumonias, but we do find them often. Bacterial pneumonias, again, this gentleman is an ex-smoker, and whether he's picked up a community-acquired pneumonia, a streptococcal or something, that's also a possibility. And in a young adult male, HIV is a possibility as well, and whether he's got pneumocystis jirovecii, pneumonia as well. And I mentioned he had a past history of intestinal tuberculosis, and there's always a possibility that patients can present with reactivation of tuberculosis as well. And we all know that the incidence of tuberculosis in the subcontinent and in the African continent are definitely higher, and that's something that we always keep in the back of our minds when we're thinking about differential diagnoses. So his blood gas showed a pH of 7.56. His PCO2 was normal at 5.1, but his respiratory rate was, his PO2 was 6.6, which is actually quite low. But if you remember, his respiratory rate was only 20. So this is the entity that we've now recognized as the silent hypoxic, or which is also referred to in literature as the happy hypoxic. But this is a type 1 respiratory failure. The other labs of note were the full blood count, which was normal, and his lymphocytes were also normal. His CRP was elevated, and his creatinine was elevated. And he had a swab done in the emergency department, the result of which was only made available about 48 hours later, because that was about the time it was taking us to get results. And he was found to be COVID positive on the swab. So that fit with our clinical differential diagnoses. So this is a gentleman who's coming in with symptoms of a pneumonia, and he's got type 1 respiratory failure. And based on the epidemiological data from the Chinese CDC, we know that you can have the majority of patients will be either asymptomatic or have mild symptoms. And only about 14% of patients present with what we call severe pneumonia, with symptoms of hypoxia, dyspnea, and the lung involvement on the chest X-ray, either at admission or within the first 48 hours, showing more than 50% lung involvement. you have to appreciate that the sensitivity of a chest X-ray is much less than that of a CT scan. Very few of these patients actually present with what we call peri-arrest situation in marked septic shock or multi-organ dysphagia, multi-organ dysfunction, fortunately. And the overall case fatality rate, keeping in mind that the majority of these patients are asymptomatic or mildly symptomatic, is only around 2.3%. But the picture is different when you're dealing with these patients who are presenting to hospital, because this is a self-selected cohort of patients who are already more poorly. And from the New York registry data, we know that about a quarter of patients who were hospitalized died, and about a quarter of these ended up on ITU, out of which 60% died. And that number hasn't changed massively even in the second wave, but these are numbers from the first wave and from 2020. And though I'm a respiratory physician and we know that it's normally the lungs that adversely affect our patients and that lead them to ending up on ITU, but you have to remember that COVID-19 manifests and affects other organs in the body. They can present with neurological symptoms. We've recognized a lot of cerebritis and encephalopathy. We've had a few patients with Guillain-Barré syndrome as well. Myocarditis and arrhythmias are actually relatively common. Again, just speaking from experience, we had a lot more myocarditis in the first wave than we've had in the second wave. We've also noticed a bit of acute kidney injury, and again, the second wave round, a lot of our patients have had deranged LFTs or liver function tests. And we've also noticed about they appear as if they're a prothrombotic phase, and lots of these patients have had clots as well. Diarrhea has been a common symptom in these patients. And again, just sharing our experience, we had a lot more patients with GI symptoms in the first wave than we had in the second wave. Now, we're now recognizing that there are different strains. The Kent strain, which, a disclaimer, did not start from Darrans Valley Hospital, but up the road in Canterbury. Then you've got the South African variant and the Brazilian variant as well. And whether they will have predominance of other organs or not is yet to be determined. So the question is, we've got this gentleman in front of us who's quite poorly and has now been diagnosed as severe pneumonia, COVID-19. What's the management? And essentially, when we were dealing with our first wave, which is about March, our first COVID patient was admitted to our hospital on the 8th of March, but the first sort of wave hit us around the 18th of March, and that lasted till about the end of April, beginning of May. And at that time, our management plan was essentially supportive care, that if they became hypoxic, we would give oxygen. If they developed temperature, we would give them antibiotics, but a lot of it was supportive care and not a lot of evidence behind that. We were using a lot of oxygen therapy. We had major issues in our hospital about oxygen supply because cylinders just don't work, and our VIE, which is our oxygen provider, is limited in how much oxygen you can provide, and that predicated what our oxygen support strategy was. And we used a lot of CPAP in the first wave. And obviously patients, if they deteriorated, were intubated and ventilated as well. And we recognized early on from the data coming out of China that these patients were prothrombotic, and we were using thromboprophylaxis as well as therapeutic low molecular weight heparins to anticoagulate these patients. But again, the evidence for any of this was very, very limited. So that was the first learning, that over the time, over this course of year, we have now come up with quite robust and evidence-based management plans. Labs are useful in stratifying and monitoring these patients, and I'll talk a bit more about that later. We recognize the role of low molecular weight heparins. We recognize that those patients who have got severe pneumonia, the risk of therapeutic low molecular weight heparin outweighs the benefit, whereas those in moderate COVID pneumonia, therapeutic fragment in the right context is actually beneficial. The definition of severe COVID pneumonia and moderate COVID pneumonia remains arbitrary as far as we can tell at this moment in time. Steroids were a big game changer for us, and I will be referencing the recovery trial for that as well. And what we learned was that these patients, we can actually get away with giving them controlled oxygen and aiming for lower saturations than we would normally recommend. Normally, the BTS, the British Thoracic Society, recommends saturations above 93%. In COVID-19, we were allowing a bit of permissive hypoxia down to 90% for those patients who did not have antecedent lung disease. And those who had antecedent lung disease like COPD, instead of 88%, we were letting it slip to about 85% as well. And these patients still did quite well. And antibiotics, we learned that actually antibiotics don't have a major role to play in these patients. We've not seen in our cohort of patients a lot of superadded infections. And a lot of the times what we're doing is that the antibiotics that are started empirically in the emergency department, we're crossing off eventually. So the labs that we normally do would be the full blood count, which includes the lymphocytes, the kidney function, the liver function, the creatinine kinase, the CRP, and the ferritin. And initially we were doing this on a daily basis with the fibrinogen and the D-dimers alternate days, but now we've come into a pattern of which we're repeating these bloods on alternate days, but also include a lactate dehydrogenase or LDH, as well as a procalcitonin to guide our treatment. And I'll talk about the prognosticating value of these labs as well. Dexamethasone, and this is the slide from the recovery trial that they published, that in those patients who were receiving dexamethasone, there was a statistical reduction in mortality compared to usual care. And I'll talk more about the dexamethasone and the recovery trial in my next presentation. And this was corroborated in this paper that came out of JAMA, which from the WHO, which was a meta-analysis from 7 randomized clinical trials that confirmed that not just dexamethasone, but hydrocortisone and prednisolone showed statistical improvement in reducing mortality. So our management changed, and we learned that dexamethasone 6 milligrams by mouth once a day works. And in those cases where dexamethasone is not available, the equivalent dose of prednisolone is 40 milligrams, hydrocortisone 50 milligrams TDS, or methylpred 10 milligrams QDS. So all of these have got good evidence base behind them that they can show efficacy and show a reduction in mortality in our patients. And subsequently, as we learned more and more, we came up with an algorithm of how to escalate our strategy and our steroids, that those patients who were deteriorating and were suitable candidates for intensive care to be intubated and ventilated, they would go off to ITU and be so. But we still were left behind with patients suffering from severe COVID pneumonia, but because of their frailty, multiple comorbidities, and patient wishes, intubation and ventilation would have been futile. In those patients, we managed them actively with CPAP or eventually Optiflow or high flow nasal cannula. And we came up with a strategy that we would start them on dexamethasone to begin with. And if they weren't improving within 48 hours to 72 hours, we would double the dexamethasone. And again, if there was no significant improvement, we would push up their methylprednisolone once daily, twice daily. And in certain patients, we were also using high dose methylprednisolone. We were pulsing them with a gram of methylprednisolone for 3 days and then going back to their steroids. There is not a lot of good evidence behind this, but this was quite commonly practiced amongst peers and fellow professionals up and down the country. And this was an algorithm that we adopted when we were trying to managing these deteriorating patients. And that brings us to the second question is, can you predict which patient is going to do well and which patient is going to deteriorate? And again, this was a very much a blank slide at the beginning of this epidemic. But with time, we have sort of understood that, yes, you can stratify patients. Those patients who have got more severe organ dysfunction or increased number of organ dysfunctions tend to do more poorly. By that, I mean patients who've got more severe type 1 respiratory failure, not responding to CPAP or high flow nasal cannula, their prognosis actually deteriorates. Or those patients who are coming in with type 1 respiratory failure, as well as deranged liver function test, as well as deranged kidney function test, as well as abnormal cardiac enzymes suggesting that they have got some cardiac involvement or some delirium or cerebritis. Generally speaking, their prognosis is much poorer. We also identified that those features associated with severe illness were predominantly respiratory. It was the respiratory failure that was killing the patients. As I said, I alluded to, we've had a few patients with Guillain-Barré syndrome, and they actually did quite well, not dissimilar to what a GBS patient does outside of COVID-19. And comorbidities, the diabetes was shown to be a poor prognosticator. Increased BMI was shown to be a poor prognosticator. And age, if you can class it as a comorbidity. And there's good evidence that the older you are, the more poorer your prognosis. And as you can clearly see, this data is from a collection of the first. We don't have the data from the second wave yet, because we're still just coming out of it. But from the first wave, when we look back, the majority of patients who passed away were over 60 years of age, and the cohort over 80 did more poorly. Those patients from a lower socioeconomic group did more poorly as well. We clearly identified that this was a sexist virus affecting men more than women. At one time, our ward was full of all of our 18 patients, bar one, were men, and half of them were black. Kent is predominantly a Caucasian population, and this was quite quickly apparent when the pandemic started that more Black and Asian minority ethnic group patients were being affected. Interestingly, we haven't seen that much gender or race discrepancy in the second wave. But again, we're waiting for the ICNAC data to come through. Lab abnormalities, again, I'll be sharing you some of the slides about what you can sort of anticipate in those patients who are going poorer. There is some growing evidence that viral factors might be useful in stratifying, but not yet entered the clinical frontier. And genetic factors, we know that the Irish seem to be protected, and those patients who are part Irish or of Irish descendancy, they tend to do better than other cohorts of patients. So what about antibiotics? And again, history is very, very important, and a bacterial pneumonia in patients would normally present with septic or toxic permanent sputum, and we were doing a lot of procalcitonin testing as well. But as I said, a lot of our patients were having typical prodromal symptom lasting from a few days to a week. Myalgia and tiredness was a very common symptom. Breathlessness, but actually not a lot of these patients had pleuritic pains, and a normal or a very low procalcitonin were all features suggestive of a viral pneumonia. And as I alluded to, we would be going around and often crossing off antibiotics that had been prescribed empirically at the front door. The other lesson we learned was that proning helps improve oxygenation. And for those of you who work in respiratory wards or in critical care, I'm sure you can share stories in which you've seen patients struggling at 80%, 77% lying on their back. Whereas if you flip them over onto their tummies, their SATs will jump up phenomenally up to 95, 97, 98%. And basically, it's all about the transpulmonary pressure. Now, and on the ITU, proning is a art form, requires multiple people, whereas our patients who are still alert and conversant and cognizant, we could encourage them. And we used to have a physiotherapist that would go from bed to bed and encouraging patients to prone. As a respiratory physician, I've been using CPAP and non-invasive ventilation for decades. I never actually got my patients to walk. And again, with COVID-19, you learn that someone who's on CPAP or non-invasive ventilation or on Optiflow, it actually is not that difficult to get them sat in a chair or actually just walking around the bed within the confines of the length of the tubing, obviously. And again, that's quite useful in getting these patients to mobilize as well. So I cannot emphasize how important this, albeit non-pharmacological, maneuver is. And so we had our information leaflets which we could give to patients, and we were telling them that from 30 minutes to 2 hours, get them to lie fully prone. Then for the next 30 minutes to 2 hours, get them to lie on their right side, get them semi-supine, then get them lying on their left side, and just as much as the patient could tolerate, get them to repeat the cycles again and again and again. And this, I cannot emphasize how important proning is. So our gentleman is now day 4 into admission, and their new score, which is the national early warning score that we use in the UK, is going off. And this is a conglomeration of the pulse, the blood pressure, the temperature, the saturations, the oxygen device, and any confusion as well. So this patient is physiologically getting worse. His ABGs show that even on 4 liters of oxygen, his PO2 is still on the low side. And he starts having MET calls. So when the new score goes above and our cutoff is 7, that's when you get the emergency team to come and see the patient. And what we did was we repeated an X-ray. And if you can remember, on the right side, he had some consolidation, whereas now we can see that there are new infiltrates on the left lung. The left lower zone is quite obscure. You can't really make out the heart border, and the left mid zone is also involved as well. So this X-ray is definitely worse from his X-ray on admission. And if we start looking at his labs, which I alluded to, if you remember, his lymphocytes were entirely normal when he came in, but over the course of the next few days, they started dropping. His LDH jumped from his admission LDH, and his CRP also started climbing upwards, as did the ferritin as well. And these are the bloods that can help stratify which way the patient is going. And we started learning and recognizing this, that those patients whose LDH and CRP and ferritin are on the rise or whose lymphocytes are plummeting, these are the patients that we tend to be very mindful of and wary that are they going to get worse before they get better. So this patient's now requiring more and more oxygen. And the question is, what oxygen should we give them? Should we just carry on giving them controlled oxygen, whether it's by a Venturi mask or a non-rebreathe? So we switched them to one of our high flow nasal cannula systems. The one we have is the Airvo or the Optiflow. These are, or shall we put them on continuing positive airway pressure? What about the role of non-invasive ventilation, the bi-level positive airway pressure? And what about intubation and ventilation? And the answer is, we still don't know what the best modality of treatment is. What I can share with you is that in the first wave, we were using a lot of CPAP, and that was quite common amongst peers and fellow professionals. A lot of it was limited by our oxygen availability. But in the second wave, we're using a lot more of high flow nasal oxygen because we've got a brand new VIE. And so we're quite liberal with our oxygen provision now, and that's made a difference. We haven't found any role of non-invasive bi-level positive airway pressure. But is high flow nasal oxygen or CPAP better than intubating the patient and ventilating them, or is it the other way around? And the importance of treating hypoxia is that if you don't treat it, these patients will start becoming more poorly, they'll start breathing more and more heavily, and they'll start getting tired, and that's when it flips from a type 1 respiratory failure to a type 2 respiratory failure, which, if not resolved, the patient will arrest. So I'm not going to talk about oxygen delivery systems, but we all have a number of these available. This is a talk for another day. We were using a lot of humidified oxygen to begin with, but very quickly moving on to our Venturi masks. And then when they're at the point of deteriorating, putting them onto a non-rebreathe and then flipping them onto a CPAP or a high flow nasal cannula. The differences between low flow and high flow, and this is why we were using a lot more Venturi, is that as the patient's respiratory rate goes up in a low flow mask, more room air starts getting inhaled. Whereas with a high flow Venturi, because the flow is so much higher, there is a fixed amount of oxygen that the patient will continue to get regardless of their respiratory rate. Non-rebreathe, or as we conventionally call it, a Hudson, you have a reservoir that you can fill with 100% oxygen, and then there's a one-way valve, so the patient is inspiring 100% oxygen. They only probably get about 50 to 55%, and then they exhale the CO2 from the one-way valves in the mask as well. So this was our sort of algorithm that we came up with, that in patients who were suspected of COVID, patients with hypoxia, we would initially lower our target SATs. And as their oxygen requirement went up, we were initially putting them on CPAP. And we came up with a strategy of starting them on 40% FiO2 with a PEEP of 5. And we went up to about a PEEP of 10 centimeters of water, whereupon at that stage, if the patient was a suitable candidate for intensive care unit, they would be transferred to the intensive care unit as well. So very briefly, continuous positive airway pressure, or CPAP, is a tight fitting mask that basically blasts oxygen through the nose and the mouth. And it's not a ventilation. And as a respiratory, I feel quite strongly about this, that this doesn't ventilate the patient. And the best example that I've always share is that CPAP is like if you're driving down the motorway with your head stuck out the window and the wind is blowing in your face. So you're breathing against a resistance, which is blowing in your face, but you're actually, it's not actually affecting your inspiration or your expiration, but you're just inspiring and expiring against a higher resistance. And that helps alveolar recruitment, it reduces the dead space, and that's how it improves oxygenation. High flow nasal cannula is a different mechanism in which we blast high flow 50, 60 liters per minute of oxygen through the nose. It does create a bit of positive airway pressure as well in the upper airways, and therefore we can deliver higher concentrations of oxygen to the patient. And generally speaking, this is much better tolerated in most patients than CPAP. However, which is better? And this is a slide of different respiratory societies up and down the world. And you can see some patients were favoring high flow nasal cannula, whereas others were favoring CPAP. And in other situations, there was clear evidence from these societies that they shouldn't use CPAP or they shouldn't use high flow nasal cannula, which reflects the lack of evidence that is prevalent. In answer to this, the Warwick group did come up with this study called the Recovery RS, or Respiratory Support, which in essence recognized that the practice in different hospitals was variable. Some patients were being treated with oxygen, and if they deteriorate, were intubated. Other patients, like ourselves, were treated initially with CPAP in the first wave or with high flow nasal oxygen. And the evidence is we didn't know which is the right thing to do. So the aim of the trial was to compare that is patient going from oxygen straight to intubation ventilation better, or should they be treated with CPAP, or should they be treated with high flow nasal oxygen? The primary outcomes were intubation or mortality, with a number of secondary outcomes. And it was an adaptive study in which, depending on what facilities you had, you could still recruit patients to this study. Now, the problem we've had with this study is that as we've been hit by the second wave and our NHS has been near on inundated, we did not have the luxury of then being able to randomize these patients into these groups, and the majority of hospitals lost the luxury of offering intubation as a first port of call. And a lot of the hospitals, because of resource limitations, ended up offering CPAP and high flow nasal oxygen and then intubating if required. So the verdict is still out on what is the best and optimal treatment strategy in these patients. The other lesson we were learning is, where can we look after these patients? These are very poorly patients. They require a lot of monitoring, whereas on our normal respiratory ward, which is a level 0 ward, would they get that level of monitoring? And different hospitals adopted different strategies. So I can share with you some of the bigger teaching hospitals. Every single patient with COVID pneumonia requiring any form of respiratory support, be it CPAP or high flow nasal oxygen, were admitted to ITU, whereas in other hospitals like ourselves, these patients were managed on level 0 wards. And this was a challenge, that are we delivering on our duty of care in the best possible way for these patients? The British Thoracic Society offered some guidelines that if you have capacity and a patient is requiring CPAP or an Optiflow, they should be moved to an ITU setting. But they recognize that when the system starts becoming stretched and stressed, that may no longer be possible. And therefore, they recognize that these patients may well need to be managed on level 0 wards with Optiflow and CPAP as well. And the Royal College president recognized that this was a significant paradigm shift from what we historically would have offered these patients, and that the 85% of these COVID-19 patients were under respiratory physicians or the medical wards, and only a fraction of these patients ended up going to ITUs. But then this offered the opportunity to think about how our services should be modified to meet the needs. And there was a talk of developing respiratory support units. And that's something that we're going down the line of, and we're still going down the line of trying to create a 16-bedded respiratory support unit at our hospital, where we can offer monitored beds to look after these patients requiring, with type 1 or type 2 respiratory failure, requiring whether it's bi-level support, whether it's high flow nasal oxygen, or whether it's CPAP. So our strategy has now changed somewhat, moving on from our initial strategies, where if the patient deteriorates and their oxygen requirements are increasing and their work of breathing is decreasing, we are moving them to the respiratory support unit, where we have higher levels of nurse to patient ratio and we have better monitoring. We happily will offer them high flow nasal oxygen. But if they continue to deteriorate and their work of breathing goes up and they now require continuous positive airway pressure, that will probably be our trigger for trying to liaise with our ITU colleagues and say, should this patient be a candidate for intubation and ventilation if it was deemed appropriate. And this pathway has become a lot slicker, and we're better able to offer this in a healthy and constructive conversations with our ITU colleagues as well. So in this gentleman's case, it was September. We had capacity in our ITUs and we got him transferred to our ITU department. They actually managed him by flipping between high flow nasal oxygen and CPAP. And though I can imagine they had some quite tense moments with this gentleman, he did not require to be intubated, and he was discharged after spending 15 days in hospital to home. And just to show that as his journey evolved, his lymphocytes initially had dropped, they sort of plateaued, and then they started picking up. And that's what we saw with the LDH as well, that its peak, it then comes down during his course of stay in the ITU, and so the PCT. The troponin also improved, and his CRP also improved. Ferritin, we recognize, takes a bit longer to settle down, and there's a significant lag in the ferritin as well. So if you remember, I was talking about using labs to help stratify which patients are going to get worse and which patients might get better. And this sort of gives you a pictorial idea that what is useful and where they can be helped predicting what's going to happen. The other lesson was that these are difficult decisions we often have to make. They are ethical concerns, and they are, especially with the lack of evidence, and having multidisciplinary team meetings. So we have a daily meeting with our ITU colleagues when we discuss some of these difficult patients, the new patients, the patients we're getting stuck, or those patients who are not improving, at 3 p.m. every single day, even on weekends, even on bank holiday, Christmas and New Year's Day. So I want to come to a second patient who is also 44 years old, female, Caucasian, who was admitted a couple of weeks ago on the 8th of February. She had tested positive with COVID-19 in the community on the 30th, and she'd been under the oximetry at home team, which is run by GPs, where they keep an eye on the oximetry levels. But her oxygen was deteriorating. She was becoming more symptomatic, more dyspneic, and she was developing a bit of a temperature. And because she was under monitoring with the oximetry at home team, they very quickly got her seen in the A&E department. Her past medical history was she was hypertensive. She had significant history of anxiety. She had a slightly impaired echocardiogram from last year, and she had impaired glucose tolerance test, and also she was on the heavy side as well. On admission, her respiratory rate was not that elevated, and her saturations on room air were 94%. And again, the differential diagnosis was lower respiratory tract infection. In the presence of being positive in the community with COVID-19, the diagnosis is likely to be a COVID pneumonia as well. And her X-ray on admission actually is a bit more telling, where you can clearly see that there's some haziness at the bottom of the left lung, but her right upper zone is quite significantly impaired and affected. Her ABG also showed her PO2 for someone of her age was relatively reduced. Her full blood count, though normal, her lymphocytes were reduced, CRP was elevated, and kidney functions was normal. And as I said, we confirmed on her COVID swab and admission to hospital that she was positive. So she was initially managed on 1 liter of oxygen. This is our news chart. And what it basically says is that this is the row of respiratory rate, that's her saturations, that's the device she's getting, and that's what what oxygen level we're entailing. And what you can see is on the day of admission, she's initially on, the first 2 days, she's on 2 liters, getting 28%. Then on the 10th, she's requiring a Venturi, so we're giving her a fixed oxygen delivery. That's gone up to 35%. And on the 11th, she's now requiring 40%. And then very quickly, she starts deteriorating, requiring 60%. And that's when she gets transferred at around 6:30 to one of the respiratory support units. And one of the first thing we did was we put her on the Optiflow, but we also gave her tocilizumab, which I'll be talking about a bit more. And by that stage, her X-ray had clearly worsened. You can see this compared to her previous admission, where she's now got probably 3-quadrant involvement of the lungs. It's probably the left upper lobe, which is the clearest part of the lung that's probably keeping her alive. So she was transferred on the 11th, and we gave her dalteparin, 7,500 units subcut BD. We initially gave her dexamethasone, 6 milligrams BD. We used the BD dose because of her weight. we started on a high flow nasal cannula, and we gave her tocilizumab on the day she was transferred to us. Tocilizumab is anti-IL-6, and I'll talk a bit more about that in my second presentation. And what we can see is that on the subsequent day, she very quickly goes down from Optiflow. So she received the tocilizumab on the 11th, and by the 13th, we're managing to get her off the Optiflow onto humidified oxygen, and very quickly, within about 24 hours or less than 24 hours, she's down to 1 liter of oxygen. And actually, we discharged her on day 7 of our hospital stay, having spent 4 days with us on the respiratory support unit as well. And we discharged her with the help of our virtual COVID ward. Again, her bloods showed that her lymphocytes gradually inched up during a hospital stay. Her LDH, which had spiked, was coming down. CRP was coming down, and also was the ferritin as well. So I just want to very briefly talk about a few things about COVID-19 that we've learned over over this last year. Different countries have got different timelines. So as I said, our first COVID positive patient in the UK was probably at the end of January. At Darrenth Valley, we had our first patient in March. And the lockdown in the UK started relatively late on the 23rd of March 2020. And it was only on the 8th of December we had our first vaccination. What we recognize is that the patients presenting with COVID pneumonia, they have an early infection stage where it's what we imagine is the viral response stage, but it's in the pulmonary phase when they start becoming more unwell and developing the severe COVID pneumonia symptoms and going into type 1 respiratory failure, which we recognize as the host inflammatory phase. And this is where we think the steroids have a role to play. But then in stage 3, there's a cytokine storm, in which we think that the tocilizumab may have a role to play in this. Now, this is all speculation, and there's some bench research that does corroborate this as well. And I suspect with time we will learn more and more about this. X-ray findings, we know that there's a lot of ground glass opacification and linear opacities as well. And if you were to do a CT scan, you can see ground glass opacification, some airspace consolidation, and some mild traction bronchiectasis. Because of our patients being on high flow nasal oxygen or CPAP, which are aerosol generating procedures, we were not able for infection control reasons to get CT scans on these patients. So we were managing these patients with X-rays as and when required. Just want to briefly talk about the statistics as well. There's a lot of jargon involved when we're talking about COVID-19. We recognize that there's geographic variations as well. Depending on how much testing you've done, your denominator changes, and therefore your ratio changes as well. There's a lot of confusion about asymptomatic spread as versus pre-symptomatic spread, and what that means in clinical terms as well, and the sensitivity and specificity of the respective tests. And whereas the sensitivity has improved of our PCR testing, but the sensitivities of our point of care testings is still not really satisfactory. But also swab techniques, and for those of you who've had swab done, I can tell you it's not a pleasant procedure. It's quite uncomfortable, and I'll confess it brings a tear to my eye. So those of us who have been self-swabbing, what's the reliability that we're having a valid sample? There's a lot of talk about the R number, and we're recognizing that whereas this was the R number that was being attributed to COVID-19 last year, but with the different strains, we think that this might be different, and it might be actually increased with the Kent strain. Case fatality rate is about 3%, but again, we know that it varies geographically. So case fatality rate in Qatar was reported at 0.05%, whereas case fatality in Belgium was reported at 16.4%. So I just want to issue a friendly caution when you're looking at these statistics as well, and they're not clean data. We can confer them to other coronaviruses that we know about, the SARS, the swine flu, the MERS, and the COVID-19. And you can see that compared to swine flu, where there were over 1 billion cases, their case fatality rate was much lower. And so the toll was much lower as well. And their R number was much lower than COVID-19 as well. So this is from the 7th of February, and we can see that different parts of the globe are affected to different degrees. But whether this is a reflection of the infectivity or whether this is a reflection of the testing and the reporting mechanisms is a valid question that we can ask. The WHO has reported over 108 million cases. This is from the 15th of February, and there's been 2.4 thereabouts million deaths since this pandemic started. But it's affected different parts of the globe differently. The Americans and Europe have been affected more, and whereas the rest of the world has possibly been affected less. Now, whether this is because of different timelines or whether this is a reflection of testing and reporting is questionable as well. There's been lots and lots of publications about scoring tools. We're medics, we like scoring tools. The clinical frailty score, which has been around for quite some time, has been adopted in the NICE guidance for COVID-19 as part of a holistic assessment, but only in those patients who are over 65, and should not be used in younger patients with stable long-term disabilities or learning disabilities or autism as well. And if you look at the literature, you'll come across different scores as well. So this is the Mulster score, which was presented at the CHEST meeting in October, where they tot up different characteristics and they come up with a severity score for COVID-19. But when you delve deeper behind the surface and you look at the citations for the Mulster score, you actually realize that this was from a single center retrospective chart of 163 hospitalized patients with COVID pneumonia in March to April. And this was derived from a study that was done in China in 2015 to 2019 in those patients with viral pneumonia, not COVID pneumonia. So you have to be mindful of this isn't the WhatsApp fake news, but there is also a lot of poor quality papers circling around as well. The NHS in some hospitals came up with a scoring tool in which they totted up this. They gave points for your age, your clinical frailty, and your comorbidity, and they came up with a number in which they would say that this patient should be for ITU, should not be for ITU, etc. And I'm just going to put a big no on that every patient should be a clinical decision-making assessment for that specific individual as well. We found prompts help, and we came up with a RAMP-T sort of mnemonic where we were reminding ourselves about the recovery trial, anticoagulation. We were using a lot more methylprednisolone initially before the recovery trial told us about dexamethasone, reminding us about proning and tocilizumab as well. And then we also came up with other prompt lists as well. These are human factors that can help us in your day-to-day practice as well. In conclusion, I just want to rattle off some other thoughts as well. So in a patient who's symptomatic with a low oxygen, with low abnormal X-ray, positive COVID swab, yes, we would give them dexamethasone and tocilizumab. In a symptomatic patient with low oxygen with a normal chest X-ray but positive COVID swabs, again, I would recommend we should give them dexamethasone and tocilizumab. A symptomatic patient whose X-ray is normal or abnormal and has got a negative COVID swab, I think you have to ask yourself questions. Is this a true negative or is this a false negative, and what the clinical picture is? And if your clinical acumen is that this patient has COVID pneumonia, then absolutely treat them with dexamethasone and tocilizumab. However, in an asymptomatic patient, if the X-ray is abnormal and a COVID test is positive, I would, at this point in time, the evidence is that there is no role of dexamethasone and tocilizumab. And in similar patients who are asymptomatic, normal X-rays, but have either got a positive or a negative swab, again, the risks of dexamethasone and tocilizumab outweigh the benefits. So the future, in October 2020, there was a talk about, evolving epidemics, and they did predict that there's going to be a second peak, which was going to be less than the first peak, but boy, did they get that wrong. We know that we got hit by a 73% increase in numbers of COVID-19 in the second wave, of which we're still just about coming out of. And modeling's talking about a third wave hitting us sometime in summer. And therefore, I think we need to be thinking about how we manage our elective work and our emergency services, and having the flexibility of ramping down our elective work to accommodate our sicker patients, and as the things turn the corner, ramping up our elective services and trying to get those patients who have missed appointments, got cancers, et cetera, to be seen. Another big challenge for us is going to be what we're going to do once these patients have been discharged home. This looks like a complicated slide, but it's a flow chart of trying to come up with a plan of how we're going to be following up these patients, and what's the best use of virtual monitoring as well as virtual appointments, and best getting them streamlined into whether it's pulmonary hypertension services or whether it's interstitial lung disease services as well. Chronic long COVID is also an interesting thing that we're beginning to see, and we don't fully yet understand this. And I think the shadow of the coronavirus is going to be long and deep. The symptoms can be a myriad of symptoms as well, and therefore you're probably going to have to do a more multidisciplinary approach to these patients with psychiatric, psychological, rheumatological support from colleagues as well. And we don't know how long this is going to last for as well, whether it's going to be weeks, whether it's going to be months, or whether it's going to be longer as well. So in conclusion, I just want to share with you that some of the lessons, that the statistics and the numbers can be confusing. And in medicine, we practice on one of the cornerstones of practice is pattern recognition. But what this pandemic has taught us is that the learnings over centuries that we base our knowledge on has been truncated into weeks to months. And in my next presentation, I'll talk about some of the learnings and how it's being applied in the clinical arena very quickly. But actually, there have been some silver linings. We have been taught the importance of learning, reflecting, discussing, and sharing. And I think this webinar is a case in point, that reaching out to colleagues and peers from halfway across the world. So I'm going to end my first talk here. I'm happy to take any questions, and I'll unshare my slide if I can.
Thank you very much, Dr. Khan, for that extremely informative presentation. I have a few questions that have been put up on the chat and that were emailed across to us, and I've tried to put them in themes. There was one very interesting one around ivermectin. Everybody says that word very differently, and
Yep.
high dose vitamin C. What are your comments with regards to utilizing this in managing COVID? Because we know that in places like Malawi, there are some people who are taking it as a prophylactic and taking it as and when they feel any aches and pains.
Yeah, so ivermectin's been brought up time and time again. There is some evidence for in vitro antiviral activity, but there is no evidence as of yet. There's a few papers flying around, but if you cast your mind back to, not probably this time, but probably March last year, where the numbers of papers about hydroxychloroquine were flying around, I think there's some analogy to that as well. Again, we'll be talking about the recovery trials shortly, but this is where the value of valid research, which has changed our management, is so important. So as of right now, there's no evidence of ivermectin. The vitamin C papers have come from ICU's papers, mostly in America. They're using anywhere between 3 grams to up to 12 grams of vitamin C. In the UK, we flog it as Pabrinex, and we have been using it in the UK. I think one of the rationale was that the risks of administering vitamin C are far outweighed by the apparent benefits. So for that reason, we are using Pabrinex, but the evidence base is very limited.
Okay, thank you for that. I think there's still a lot more work to be done with regards to research around these. Other questions around oxygen and management of patients who are desaturating. So there's 2 questions. One is, what is the best position to nurse COVID-19 positive patients that are desaturating whilst on oxygen therapy? And does it have to be humidified oxygen at all times on? And the second one is, a gentleman called Douglas, he says he's interested to find out, how do you get patients who have been on long-term oxygen therapy off it? Because it seems that most people, once they come off, they tend to be stuck. Their saturations tend to be stuck in the 80s. So how do you manage to titrate them down to a place where they go back to a normal rate where they're breathing on their own?
Right. So the first question, sorry, was about, you have to remind me, I've lost the thread now.
So a patient, just asking about how do you best nurse a patient who's desaturating whilst on oxygen therapy, and whether they have to utilize humidified oxygen all the time or not.
So what we do is, we prone them, because obviously these are awake patients that we're talking about. I don't work in an ITU environment, so these are awake patients we're talking about with varying degrees of BMIs. And some of our patients, we have seen during this second wave more increased BMI patients than ever before. And some of them physically cannot lie on their stomach. So one is, it's a pragmatic thing that you try to get them into a prone position as much as they can tolerate for as long as they can tolerate. The other thing you have to imagine is that we talked about transpulmonary pressures, and that different parts of the lungs are affected differently. So there is a possibility that in certain positions, patients can desaturate as well. So the important thing is that get them into a position that they can tolerate comfortably for anywhere between 30 minutes to 2 hours, provided they don't desaturate, and then move them into another position, then move them into another position. And it's just a continuous prompt and a continuous trying to encourage them to tolerate it as best as possible. We do use humidified oxygen, but the problem with humidified oxygen is that these are variable performance masks, and if the patient's respiratory rate is going up, they'll actually start entailing in room air. So we then switch to Venturis, and if needed, then we put them onto high flow nasal cannula and CPAP. Your second question was about weaning these patients off oxygen. Yes, so not all patients are the same. Some of these patients will develop fibrosis, and in those patients we're giving more protracted courses of steroids, and some of them we have sent home with oxygen. These patients will be developing features of organizing pneumonia as well, and again we're giving them a slightly protracted course of steroids. Those patients generally don't desaturate as much, and we're able to wean them off. Rehab is a very important component in their recovery, and getting these patients to try and exercise as much as they can. What I normally tell them is that some days they'll feel really good, and that's the time to do more. Other days they won't feel good, and it's important to try and, but this is where there's an overlap from recovering from a severe COVID pneumonia going into chronic or long COVID, and whether there's psychological elements, whether there's an element of post-traumatic stress disorder, anxieties, and whether these patients have developed other complications from COVID-19. But yes, significant percentage of our patients were able to wean them off oxygen more quickly and send them home on room air. Some of these patients we have sent home on oxygen, and a year later they're still on oxygen. Not a year later, but 10 months later, they're still on oxygen. So we've got a few patients from our first wave who one of them was one of our midwives. She is looking to return to work, probably in a limited capacity, but she's still on oxygen.
Okay. So this is one of the topics that needs to be looked at when we're looking at long COVID, isn't it, with regards to how people are managing oxygen and living with oxygen therapy after they have actually survived COVID-19. You did allude earlier around the fact that COVID is being sexist in how it's presenting. We do know in general terms that men tend to present very late with regards to any health issues, unlike women. Are there any particular reasons why men are more affected by this virus?
So just wanted to share that this second wave, the virus is not as sexist.
Okay.
So we're seeing a lot more females, and it's I don't want to say 50-50 because I don't have the data to back it up, but it's not far off from that. So and there's I sort of alluded to that. We do recognize there probably will be some genetic factors that predispose patients to COVID as opposed to others. Again, just to share with you, we've had a number of patients with lymphomas and hematological malignancies. I think we only have one who's doing well, who's still an inpatient at the moment. Everyone else of our hematological patients have died. And again, we don't fully understand that. We've treated the patients no differently to our COVID cohort, but these are initial observations. And I didn't want to go into these minutiae because I don't have answers for them either. But, and this is what I'm meaning, what lessons learned. Maybe that's another lesson we're going to learn a few months down the line about we should be managing those patients differently. But as I've sort of alluded to in the first wave, in the beginning weeks, we had practically no evidence-based medicine. Dexamethasone was a game changer. And then more recently with tocilizumab, and I'll share with you some of the data in the next presentation about how the position of tocilizumab has changed in weeks, in the last few weeks alone. And there's some news hot off the press from just yesterday, which I'll share with you as well. Obviously, this is all UK MHRA evidence as well, but it reflects the real world we're living in and the challenge we're facing.
Okay, I think some of the questions you have answered in your presentation with regards to PEs and comorbidities and so on. There is a question around vaccinations, but I'm going to leave that until you do your second presentation because I think you might touch on that.
No, I'm not going to touch upon vaccinations.
Touch on that. Okay.
Am I not mistaken? You had a webinar on vaccinations.
Yes, we did.
Not long ago.
Did.
So
yeah.
I think you're probably more in touch with the experts than I am.
Okay, well, I will ask it later on so that it can just be a point just to sort of get a comment from you on the vaccinations. I'll actually throw the floor back to you because I am aware of the time so that you can do your second presentation and then we'll collate other questions and then ask you after that. Is that all right?
Yep, that's fine. So Brilliant. Can I just check that you can see my slide? I don't know what you can see.
Yes, it says COVID-19 recovery trial.
And is it just the big slide or has it got on the left-hand side?
We've got on the left-hand side the rest of your presentation. Are you able to put it in slideshow mode? If you tick at the very top, I think it's it's the sixth, the middle tab. It says slideshow. If you click on that.
Oh, sorry, I'm trying.
So you've got the tab on the home. Yeah, there you go.
Has anything happened?
It's taking its time. There's a comment on your tab. Resume slideshow. So it's asking you to resume the slideshow. Yeah.
Anything?
No, it's all right. If it's not happening, you just go ahead.
Let me just try one more time.
Okay.
Is that any different? Probably not.
It's not any different.
Okay. So what I'll do is if I get rid of this so that at least I can make it bigger.
Yeah,
And
that's better.
if I hide this. Okay, so we're going to be talking about the recovery trial, which was started from the Oxford group, and it started sometime around the time we started learning about the COVID pneumonia, where we were having lots of data coming out regarding hydroxychloroquine and whatnot. Um, and we signed up at Darren Valley Hospital to the recovery trial in March, early March. So we've been amongst the early adopters of the recovery trial as well. And initially, the trial design was that all eligible patients, so these are confirmed COVID pneumonia or suspected COVID pneumonia on clinical grounds, provided they provided informed consent, and we would then randomize them into a group in which they received no additional treatment, and at that time we were giving them supportive treatment, paracetamol, IV fluids, oxygen. The second group got Coletra, which is a well-known antiretroviral drug, dexamethasone, hydroxychloroquine, and azithromycin. And then they were followed up until 10 days or discharge, and their outcomes were noted. Um, um, and not long after, I can't remember, I think it was probably April, the tocilizumab, which is an anti-interleukin 6, was also added. And so the criteria, the trial changed, that patients were randomized to one of the 5 treatment arms, and if they remained poorly and were still within 21 days of admission and had a CRP of more than 75, they could then be randomized to receive or not receive tocilizumab. So in essence, a patient would come in and they would be randomized to whether they got dexamethasone or hydroxychloroquine or azithromycin or Coletra or no additional drugs. And then each of these patients, provided they were within 21 days, not getting better and at a high CRP, could then be randomized a second time to receive or not receive tocilizumab. And then they were followed up for their outcomes as well. So hydroxychloroquine obviously was a lot in the press, and you had proponents like the now ex-president of the United States purporting its usage. There is very good in vitro evidence that hydroxychloroquine has got antiviral effects. It inhibits the virus entering into cells. And there were a few papers from France and from China which showed some benefit in those patients who were treated with hydroxychloroquine. And for lots of people around the world, hydroxychloroquine is common parlance in the subcontinent, in the Pacific Rim countries, in Africa. Hydroxychloroquine is something that is relatively easily available, relatively safe, and relatively cheap as well. But very quickly, they published their data in which this shows that on your y-axis, you have percentage of death, and on your x-axis is time. And what you can clearly see is the orange line showing that there is an increased tendency to mortality in the group receiving hydroxychloroquine. Now, this is not statistically benefit, but what you can clearly surmise from this study is that there is no efficacy or benefit from hydroxychloroquine in this group of patients. So the recovery trial concluded that there was no meaningful benefit of treating patients admitted to hospital with COVID-19 with hydroxychloroquine. But we recognize that in different countries, America, Brazil, India, there was a lot more usage of hydroxychloroquine. Just to share with you, in India, there was a government missive stating that all healthcare professionals, i.e. nurses, doctors, should take either treatment dose hydroxychloroquine or prophylaxis with hydroxychloroquine as well. Dexamethasone was the next drug in which we got some information, and because the study recruited 2-to-1 in the standard group versus the drug groups, once they got 2,000 participants in the dexamethasone group, they stopped recruiting more patients into the dexamethasone group, and their 28 mortality showed a statistically significant reduction in mortality in all patients who were receiving dexamethasone versus standard care. When they analyzed the data even further, they realized that those patients who were on higher forms of respiratory support, that is by ventilation or ECMO or forms of oxygen, the statistically significant benefit was more, whereas those patients who were not receiving oxygen, there was no statistical benefit of administering dexamethasone to this cohort of patients. And if you think about the cohort, these are slightly older patients with increased BMI, possibly pre-diabetic or diabetic, steroids can actually be detrimental in this group. Whereas if they were on oxygen or in the ventilator or ECMO, the benefits outweighed the risks of giving them dexamethasone. So this was a massive game changer for how we were tackling our patients with COVID pneumonia. So the recovery trial concluded reduction in risk of death among patients admitted to hospital with COVID-19, increasing benefit with increasing level of respiratory support, and the numbers needed to treat were 8 ventilated patients to prevent 1 death. And again, the silver lining was that dexamethasone is widely available and relatively affordable. And on my first talk, I also showed that the other drugs, prednisolone, hydrocortisone, and methylprednisolone, also in other different studies showed therapeutic efficacy in the reduction of mortality in patients with COVID-19. So the recovery group published their data, the preliminary report, in July of last year in the New England Journal of Medicine. So subsequent to that, the evidence showed that there was no evidence that, so as I've said, there's no evidence that hydroxychloroquine works. The evidence was that dexamethasone did work, and that then became part of standard of care and therefore was removed from the trial, meaning that all patients who were being recruited into recovery trial who were not randomized to the drugs would receive whatever drug is right, whether if they were on oxygen, they'd get dexamethasone. If they weren't, they didn't. But Cletra, again, didn't show any therapeutic benefit either. And the azithromycin arm was continuing. So a very long time, patients were randomized either to receive standard of care, which may or may not include dexamethasone, or azithromycin. And again, with the same criteria, not getting better, 21 days, high CRP, they would then be randomized to receive or not receive tocilizumab. Convalescent plasma came out in the middle of last year that pooled plasma from patients who have recovered from COVID-19 and have antibodies, and the convalescent plasma entered into the 2 big studies, which was the REMAP-CAP and the recovery trial. And so, and at around this time, aspirin also entered into the study as well, and therefore patients were randomized to either receive standard of care alone, or standard of care with convalescent plasma, or azithromycin and convalescent plasma, or standard of care and azithromycin, or triple therapy, whether that be standard of care, azithromycin and convalescent plasma, or azithromycin as aspirin and convalescent plasma. Not long after, Regan-CoV-2 monoclonal antibodies were also introduced into the recovery trial. We never at Darren Valley Hospital were able to get monoclonal antibodies as part of our trial because we had issues with pharmacy and the safe administration, the safe constitution and administration. So we were excluded from that arm. But so the drugs were standard of care, aspirin, azithromycin, and convalescent plasma. And again, the same criteria. They were randomized at a later time to receive or not receive tocilizumab. On the 15th of January 2021, the recruitment into the convalescent plasma arm stopped, and they had enough patients to say that there was no convincing evidence that there was any mortality benefit from convalescent plasma. The other issue with convalescent plasma is that these patients were then told they had to wait, I think it's 60 days before they could have their vaccine as well. So the modified trial then came to standard of care with one arm getting aspirin, the other arm getting colchicine, which is an anti-gout medicine, and the monoclonal antibodies in those centers that could have access to it. And again, the option of randomizing patients to tocilizumab to receive tocilizumab or not receive tocilizumab. Just want to talk about tocilizumab. It's a drug that is well known to rheumatologists. It's an anti-IL-6. What we recognized early on was that there's an excessive inflammatory response. Monocytes and T cells have an aberrant compared to normal, and they express interferon and GM-CSF, and they release interleukin-6. And this has been widely recognized in both the pulmonary circulation and in the systemic circulation as well. And then as the interleukin-6 enters into the lungs, it causes exudate and inflammatory cellular infiltration and can result in an ARDS type picture, or adult respiratory distress syndrome. So REMAP-CAP is a randomized multifactorial adaptive trial that is being run in ITU for pneumonia. And what they were comparing was tocilizumab versus standard care in intubated patients. And what they proved was that the median number of days free of organ support was statistically higher. There were fewer in-hospital deaths, 28% versus 35.8%. And significant improvements in other outcomes like survival time to discharge and time to hospital discharge. That was in the intubated group, but they also found in those patients receiving tocilizumab who weren't intubated but on ITU, fewer required intubation, fewer required ECMO, and fewer patients died. So they announced their findings at the end of December, and the Department of Health and Social Care in the UK released this position paper on the 8th of January, stating that those patients admitted to ITU with severe pneumonia, even if they were on high flow nasal oxygen or CPAP, would benefit from tocilizumab, and we were allowed to give it. The dilemma we had was, as I've explained in my previous talk, where a lot of these patients weren't being monitored on the ITU or weren't being managed on the ITU. And so we went into this sort of quagmire that these are patients who've got COVID-19, are on CPAP or Optiflow, but are on a medical ward. How can we get tocilizumab? And it might sound silly, but we really struggled with getting tocilizumab for these patients. NICE, which is the National Institute for Health and Care Excellence, they published their rapid summary on the 15th of January, where they just corroborated that if you're on ITU, it is beneficial and you can get it within 24 hours, but it didn't really categorically say that what about those patients who are not on ITU or not requiring intubation and ventilation. On the 25th of January, Recovery Trials sort of weighed in on this as well, and they showed in their chart that the only out of the 7 trials in which they've used tocilizumab, REMAP-CAP was the only one that showed statistical efficacy, that interleukin-6 antagonists showed any benefit as well. But last Thursday, Recovery finally released their data. The number of patients in Recovery trial who received tocilizumab, the total number were in excess of all of the patients in these 7 trials, numbers wise. And they had 2,022 patients who had received tocilizumab, and they showed that there was a statistically significant reduction in deaths, 29% in the patients in the tocilizumab versus 33%, as well as other benefits of invasive ventilation and those patients not intubated and ventilation as well. And then on the 17th of February, which is yesterday, the Department of Health has now agreed that for those patients who have got COVID pneumonia with requiring oxygen, high flow nasal or continuous positive pressure airways or invasive, we can administer 1 dose of tocilizumab. And we've been using this now for the last 2-3 weeks, and we've seen a massive change in the outcomes of our patients as well. And I gave you the second case vignette I described was a lady who received the tocilizumab and then her turnaround was quite impressive as well. So until a couple of days ago, the current recovery trial is comparing aspirin with usual care, the monoclonal antibodies versus usual care, or colchicine versus usual care as well, and then following them up. But there's been a new drug admitted, another JAK protein inhibitor, which is called baricitinib. And so the new model will look like that patients will be randomized to either receive colchicine, aspirin, baricitinib, or the monoclonal antibodies, or usual care alone. And that's where we are as of this moment. We've started using baricitinib. Charlotte might be able to tell me whether any of our patients have received baricitinib at Darren's Valley Hospital, but we've only just started receiving baricitinib. So in conclusion, recovery remains the largest global trial in COVID-19 and is an exemplar of what trials can do. I think you can clearly see that sometimes the message can change over the course of days, and we still have more drugs in the pipeline that might also show some therapeutic effect as well. The recovery website is open access to everyone, and if you want to go and see more information, and there's links for healthcare professionals as well as patients links as well, and there's got some really good videos on that. It's easy to follow, which can be more informative as well. Thank you. Over to you, Salah.
Oh, I had to unmute myself. Thank you so much for that, Dr. Khan. I do appreciate that we've had you talking for such a long time, but I think this is a very important topic, and people are open to learning, and we want to understand what you have learned currently and where you're going with what you've learned. I do have a couple more questions, but before I do go forward, Charlotte just answered that yes, they do have a couple of randomized patients on baricitinib at the moment. So that's an answer to your question. And just to let you know, we do have Dr. Maggie Nyirenda here with us. And because she's here, I'm going to take advantage of that and maybe just ask the vaccine question so that she might answer that and you might give a comment towards that. Is that all right? So the question was whether you may have seen any impact with regards to COVID-19 vaccination. So we have started our rollout earlier this January, and has there been any impact clinically or that you might have seen with regards to us undertaking the vaccination rollouts? And another question was, is the vaccine effective against any variant or specific strains? So Dr. Maggie Nyirenda, are you online? Dr. Maggie?
Maybe she's dropped out, Sarah.
Oh, okay.
Yeah,
okay.
Yeah.
Okay. All right. Maybe she stepped out. Dr. Khan, would you have any comments to that?
So in answer to your first question, it's very difficult. And as I think the metaphor, you know, you're so close to the tree that you can't see the woods. I think that applies to as a respiratory physician to my case. Just to share with you, since the first week of March last year, we've gone probably 2.5 weeks when we had 0 COVID patients on the respiratory wards. So that's the nature of, you know, that as the numbers drop, but those patients will get more and more filtered towards us. So I can't provide you with a bird's eye view of whether or not the vaccine has kicked in yet or not. I think lots of people have been shielding. The vaccine is going to have an impact on people getting back to normality. There is some modeling about a third wave, as I showed you a slide. So I'm not an immunologist, and I don't want to overstep my remit into that field. And sorry, you had a second question again, or second part of that question, which was?
Is the vaccine effective against any variant or specific strain? So I know we've got loads of different vaccines, but currently we have the AstraZeneca and the Pfizer here, and I think the Moderna is coming. But with Pfizer and AstraZeneca,
So,
and I think AstraZeneca in particular, because that's what Malawi will be getting.
right. So the answer is, as of now, I can't give you a categorical answer. I know the FDA in America is looking with some cynicism at the AstraZeneca vaccine. Now, what the evidence is or what the context of that is, I don't know. And again, I think the one thing we've all learned from COVID-19, one of the other lessons is that to share uneducated opinion has also got its risks as well. And a lot of the times I have been, I probably frustrate colleagues when they ask me questions and I say, watch this space. And I think that's going to be the point. Just to share with you, we've had our first vaccine and we've not had our second shot. So, you know, we're in the hands of the lay of the land and the national predicament. And I suspect different areas in the country and different countries will have similar challenges as well.
Yeah, I'm just going to let my audience know that we had another webinar with, is it Dr. Master Ponda? And some of these questions were answered in there. So just contact us and we can see how we can make that information available to you. Another question around PEs and DVTs. So is it true that after recovery from COVID-19, people can present later with clots, DVTs or PEs? And should they be taking anticoagulants in the interim or long term? I think we've had instances where in Malawi, people are taking aspirin once again as a prophylactic, and it seems they want to stay on it for long term, and that has its risks. So, the
evidence for, we know that COVID-19 is prothrombotic. The evidence, but again, the evidence, I just want to rattle off a few evidence pieces that we do have that across COVID-19, the evidence of intermediate dose low molecular weight heparin is very clear. The adverse outcomes of therapeutic low molecular weight heparin in severe COVID pneumonia is apparent. However, in moderate cases, there is supposed to be some benefit. That comes with a pinch of salt in knowing what the definition of severe and moderate is. There is, and again, there's no categorical evidence, but there are different policies and guidelines that, and I can just share with you what we do at Darren's Valley, that we do a improv score. And if the improv score is 4 or higher, then we do recommend that these patients go home on 2 weeks of thromboprophylaxis, provided the Hasbled score is lower. What you're describing about aspirin is also quite common. Obviously, within the NHS, the prescribing is a bit more regulated. In other parts of the world, there's probably more access. Yes, aspirin does have its risks, and again, it's about risk and benefits in individual patients. But as of this moment, there is no categorical evidence on what we should be really doing. I can share with you best practice. The best practice I've told you is patients with a higher risk of thrombosis with low risk of bleeding, we are sending them home on 2 weeks of thromboprophylaxis.
Okay, so that's in the interim. Brilliant. We did touch a little bit around vitamin C. Another question popped up around vitamin D. Any comments on utilizing vitamin D as part of treatment for COVID-19?
So yeah, I should have touched upon that. There is some evidence, mostly from the States, that check the vitamin D level and prescribe. We know that there's lots of evidence of association between vitamin D and lung problems, pneumonias, tuberculosis. And again, our current practice with very limited evidence base is the risks of administering vitamin D is outweighed by the benefits. So we do administer vitamin D.
Okay, brilliant. So when you were telling your story around managing patients on the ward, you did state that you noticed that there was a higher number of BME individuals who tended to be severely ill with COVID. And we've had in the first wave, a larger number of people from a BAME background die from COVID-19, even though we are considered a minority in this country. The question is, in particular the first wave, because we have information and data around that, why are the numbers of ethnic minorities lower in places like Africa or Asia or Europe and higher here in the UK?
That's an excellent question, and I can't answer it. Whether it's to do with the age of the population, so the average age in the subcontinent and Africa is much younger than in the UK. Whether we're seeing a sub-selected group of these patients, I've shared with you that the majority, or at least 50% of our patients in the first wave were BAME. The second wave, that's not the case, but we've had a number of BAME males in the second wave, 47, 48, 49 who've died. So that doesn't help. That's slightly anecdotal. And I think this will be an area of interest and research in, as I said, there's going to be more lessons to learn.
Mm-hmm. I mean, we are aware there's currently a lot of research that NHS England and other bodies are undertaking to sort of try to answer this question. So we are going to watch this space again.
Yep.
Another question around pain management with regards to pethidine. I do know that you stated that you're not within ICU or critical care, but the question states, is it appropriate to administer pethidine in patients that have been intubated or ventilated?
So I mean, whether it's pethidine, whether it's a benzodiazepines, or whether it's opiates, yes, there's good practice of that. There's no real harm that we can tell. Obviously, these are patients who, the ones on the CPAP mask, are a bit distressed, a bit agitated. So, yep. I know some ITUs are using remifentanil as well. So, yep, it can be done very safely. Different hospitals have different practices. We use sublingual lorazepam, and we do use Oromorph as well.
Okay. Another question was, it's put out that it's a myth. So is it a myth that cigarette smokers are less prone to COVID-19?
That's a myth.
That's a myth. Okay.
Yep.
What's the fact then?
Yeah.
Can you clarify?
So the risks of cigarette smoking, and that's another talk for another day that I'd be happy to give. Cigarette smoking or cigarette cessation is a topic very close to my heart. No, there is absolutely no evidence that cigarette smoking is protective in COVID-19.
Okay, I see a hand from Oscar Mahango. Do you want to ask your question? Just unmute your mic.
Yes, I do. Do I have to be on a video?
Either way, because I know you're calling from Malawi, so that will be welcome.
Yes, from the home heart of Africa. So that's, I thought I have to be on a video. Let's go ahead. I think the question which Sarah just raised, or someone else might have raised, and you're voicing it on their behalf, about the numbers of BAME community that really died, especially in the first wave. I think most of us work in the hospitals, so we know what happened or what did not happen at that time. The question, although you posed, Dr. Khan, I think is unfair on him in a sense, because there's a lot of political and social issues around that, and we can discuss that maybe at another much deeper level. I suggest that one of the reasons why there was more people who died of the BAME community, there was a lot of fear at that time, and I also understand this social setting that we work in. We may beat about the bush, but I can just say straightforward that there was discrimination, or there was evidence of discrimination, where there's some people who were dumped essentially and died from just from having poor care essentially. It may be too straightforward in the sense of blunt, but I think that's a fact, or at least some evidence to point towards that direction. So I don't think that was fair on Dr. Khan to ask him why do you think that is the case? I would suggest that was part of the reason. The second wave, I think there was a lot of awareness, there's a lot of or there's been a lot of confidence, and people were able to work with people with COVID, knowing that they've got the right PPE, and they would go ahead with confidence. But the first wave, I think there was very much a question of those who are in the minority were dumped. It's a fact, maybe not the fact, but I think it is. There's some evidence on that. I'm sorry to be so blunt, but that's what.
So the only thing I'm just going to add to that, which is that if you look at the data of healthcare professionals in the UK who have died, the majority of them are BAME. We lost one of our colleagues, a consultant hematologist at Darren Valley Hospital last year. So I think, I think there is a lot more awareness and there's a lot more research happening. And if I can just leave it at, I think there are lessons to learn. Whether the lessons are medical, scientific, social, and cultural remains to be seen.
Thank you very much, Oscar, for calling me out and chastising me for putting Dr. Khan on the spot.
No.
That's what we need. We need Oscar is a fellow practitioner, even though he's down in Malawi, and he was around in the first wave up here in the UK. So he is aware of the situation that was on the ground and was working on the front line. So issues around PPE, issues around our fellow BAME colleagues being afraid to speak up and to ask for help. So like you were saying, there's a lot of other underlying causes around that. I do have a question around maternal outcomes with regards to the treatments that you spoke about. So is there any evidence of these drugs having any effect on maternal outcomes, especially if delivery of babies is through C-section after receiving a COVID-19 treatment?
So from a recovery trial perspective, colchicine is contraindicated in pregnant patients. We've had a spate of pregnant patients who have deteriorated very quickly, requiring emergency C-sections and ending up on the ventilator as well. But I don't think we have enough experience, exposure, and numbers to give a more evidence-based answer. The uptake amongst pregnant patients and pediatrics in the recovery trial has been relatively low, but Charlotte, and I notice Anchor's also online, they probably have the numbers on their fingertips, but I might be unfairly putting them on the spot as well. But yeah, I think we've recruited one patient in the recovery trial for pediatrics. We've had a few pregnant patients who've been admitted and treated on the recovery trial as well. And we've been quite proactive in our recruitment to the recovery trial. I think we're the second highest in our region.
That's
but
brilliant.
Yeah.
Brilliant. This one is a bit more generic, more of a statement, but I think I would seek some advice from you because it's actually also happening in Malawi. So in the first wave, patients were told to stay home until an ambulance comes to pick them up. Was this the right approach, do you think? Now patients are coming late and they're being blamed for coming late to hospital. So a lot of people in the first wave were told, come when you can't breathe or you're finding it difficult to breathe or when your saturations are down to about in the 80s. Would you have any comments on that? Because we see a lot of people coming in.
So in the first wave, we didn't have any oximetry at home services. Now a lot more. I mean, in the UK, the pulse oximeters are relatively affordable. GPs are distributing them to most patients who are symptomatic, and they have got processes and systems in place where we have quite a robust. And the second patient who I presented, Miss KB, that she had only turned, she sort of dipped, and she was in hospital straight away. So I think there's so many variables, And just to share with you that we were just having this conversation earlier today, that with tocilizumab now being administered to patients who are even on 40 to 60% of oxygen, not even on an AGP, what about all those patients that we didn't give it to in the preceding weeks and months? So there's so many variables, and we've all got, those of us who've been on the front line, we've all got anecdotal cases in which we treated patients to our utmost, and despite that, they still didn't survive. And I shared with you my experience about the hematological patients as well. So it's you know, and for those of us who practice in hospitals, we also know it's not a level playing field. It depends on what time of the day you come, and this is evidence-based. We know patients being admitted on a Thursday have a longer length of stay as opposed to those admitted on other days of the week. So there's so many variables in the answer to this question. So I think it's unfair and possibly unprofessional to tell any patient, oh, you've waited too long. That's the last thing they want to hear. It's not very helpful, to be honest. And we can share our experiences with lung cancer. You sort of alluded to men presenting later and with more symptoms. I'm sure in other resource poorer countries where primary care services are limited, the challenges are so profound to presentation.
Okay. I just want to ask, is Dr. Maggie Nyirenda around at all? Has she come back, or she just completely dropped off? Okay, because I was trying to find out how applicable what we have heard from you is. How is it applicable onto the ground in Malawi? And if there's somebody in Malawi who would be brave enough to sort of speak in regards to what Dr. Khan has said, just to comment if that is something that we are doing on the ground in Malawi, or if that's something that is applicable or can be transferable, or that we're doing different that's working with regards to managing COVID-19. Do we have anybody in our audience? I'm throwing it out to the audience. Going once, going twice. Brilliant. Okay, so
if I can just interject very quickly, I think the way I structured the talk was to share what we were doing in March and April last year, and what we've learned and what we've changed, and to share that even when we had no evidence-based treatment modalities, this is even before we had steroids as part of our standard of care, patients still survived with supportive care, with a bit of oxygen, with a bit of, and not a lot of our patients went to the ITU either. So, so COVID-19, depending on the patient comorbidities, we talked a bit about stratification of which patients are going to deteriorate. So it's, and the majority of patients, fortunately, who get COVID-19, hopefully will never see a hospital either. So, but obviously we always think about the worst cases, the ones that are more severe, and the ones that we feel that we could have done more, and we share that journey as well.
I think that the key thing is with COVID-19, it has been a bit sensitive. They've made it, there was a huge focus on patients within critical care. I come from a critical care background, and listening to you from how you were managing COVID patients on the ward it's such an eye-opener to say that it is not always people coming into critical care, but people are living with it, they're managing with it, some are not even coming into hospital. And I think this is very practical for Malawi especially, where we don't have a lot of ventilators. I think we've probably got a handful in the whole country, where we can learn that it is possible to manage people with the few resources that we have. And I think for me, this has been extremely, extremely helpful, and that we have learned a huge amount from you, Dr. Khan. And for my audience out there, I just want to say a massive, massive thank you. Dr. Khan has You are a well of wisdom. I mean, he's got papers out there, numerous papers. So please do Google him and look through some of the research that he has done. But before I close, I want to ask Charity if she's got anything to say. Charity, do you have any comments?
No, thank you so much, everyone. And thank you so much, Dr. Khan, for coming and for sharing this. It's been a huge, it's been a huge learning curve for everyone, and more so for Malawi, because in Malawi, there was a little bit of complacency in the glaring evidence that there was going to be a second wave, and it really took us Malawians, all Malawians in Malawi, by surprise. So there was a lot of talks with regards to non-pharmacological management, pharmacological management. People were buying dexamethasone, probably taking it as a prophylactic, ivermectin, everything that they could hear that was out there, you know, on social media, that it helps. So this just provides some insights and helps in some ways management of COVID. We don't have a lot of ventilators in Malawi. At our main referrals hospital, probably all the three would say we've got maybe 12 ventilators. And this is against a population of 18 million. They've had a lot of admissions, and mostly hearing from the ground, our patients have been managed by the nanny breathe back. They didn't even have a high flow, some with high flow oxygen, but very few. We did run out of oxygen quite a lot in hospitals, and we had some stories of whereby oxygen was being rationed. So it is a huge learning curve, but this has also provided an opportunity for people to come together and pull up resources, and even having this webinar would take some things home and see where we can improve. So thank you so much for sparing your time, you know, your afternoon to just help us. So I really, really appreciate on behalf of all Malawians and the audience. Thank you.
No, it's been an absolute pleasure. You've been a wonderful audience. Thank you.
Thank you so much, Dr. Khan. We have tried to stay to time. I know we've stepped over a bit, and we appreciate that your time is very precious. So thank you very much for your time. And I know Charlotte will probably be in touch. There are a few topics that have come out there that we might call you back to speak on. So thank you so much. And to my audience, if you have any more questions, you can always email them to us. We will try to relay them to Dr. Khan as best as we can and get the answers back to you. So we'll stay in touch. There'll be more webinars. Watch this space, as Dr. Khan says. Thank you so much, and have a good evening.
Yeah, goodbye.
Thank you. Goodbye.